So I'm going to talk about rheumatoid arthritis of the wrist today. And I gave this talk about 10 or 12 years ago and updated it. And what I found is from the orthopedic literature, there's not a whole lot of advances in what we do orthopedic-wise. So it's pretty similar to what it was 10 years ago, but from a medical standpoint, there's been a lot of advances. So I do have some added slides on the medical management of rheumatoid arthritis on this talk. What I wanted to go over today is pathophysiology and then how the wrist disease progresses over time in the rheumatoid patient. And then it was an interesting study looking at perspectives of rheumatologists versus hand surgeons in treatment of the rheumatoid wrist. That can give you some insight on how the medical field looks at it versus how we look at treating these patients. And then some of the advances in medical management. And then the second half will be surgical indications, preoperative planning, and then different aspects of surgery, soft tissue surgery versus bony surgery on the wrist. So in general, rheumatoid arthritis affects about 1% of the US population. It's basically a chronic disease that lowers the quality of life and increases mortality and morbidity related to the extra-articular manifestations of rheumatoid arthritis. A couple notes on these patients and their ability to work. What they found is 1/3 of patients were unable to work 5 years after the diagnosis, and at least half were work impaired by 10 years. So it does affect younger patients. I do see a mixture of patients presenting later, like in their 60s, but a lot of these patients can present in their 30s and 40s, so it can be during their work years. The question with that is, if these new biologic agents are going to have some effect on these patients' ability to work, their work-life endurance. And one thing that I found that affected work life was physical limitations. If you look at their quality of life scores, if they had higher mental illness or physical limitation scores, they were less likely to have a full work day. They were more likely to miss more days and not work as long. So we know that the biologics do improve in both of those categories. So the question is whether these patients are going to be able to be employable for a longer period of time with the advances in medicine. For the etiology and pathogenesis, I mean, there's books on this, so I'm going to simplify it dramatically here. The etiology, patients have a hereditary predisposition to developing rheumatoid arthritis. And they have some genes that they've looked into that are linked to it. But what happens, and we don't know why this happens, but something triggers them to develop the rheumatoid arthritis, and then something perpetuates it. So there's been all sorts of theories, from smoking to hormonal changes to some kind of infectious etiology to toxins, but they really haven't figured out what triggers that. But once it's triggered in patients with seropositive rheumatoid arthritis, you guys know what we check for in the blood for CCP and RF. Okay, and those are autoantibodies. So those are the seropositive patients, but there's seronegative patients that do not have those autoantibodies circulating in the bloodstream, so they can test negative. From that, a lot of the immune system's turned on and it's overactive, and what you get is this pannus that forms within the joint. If you look on here's the pannus that develops in the joint, so it's hypertrophic synovium and just a lot of inflammatory tissue. And they have inflammatory cells in there, in those structures, and then you get synovial fluid. But ultimately, the products of that pannus destroy the cartilage, followed by the soft tissues around the cartilage, and then you can get bone destruction also. the only reason I put this on here is to show you how complicated the biochemistry and the cellular level and all the different cytokines can be that lead to this problem. If you look at how the biologic DMARDs work, so you have the DMARDs like methotrexate and some of the other ones, but these are the biologics are the ones that are the TNF inhibitors and the IL-1, IL-6 inhibitors. So they're further down on the chain and they're directly inhibiting the cytokines. Those are, TNF is a cytokine and so is interleukins. They inhibit that. And those they feel are responsible for whatever triggers inflammatory response and turns on all the cells to start doing the destruction. So that's been major advances, the different biologic DMARDs. We'll talk a little bit about them in relationship to surgery later. So if you look at the progression of the disease in the wrist, frequently it's the earliest site that you'll see in rheumatoid arthritis. And it can be quite subtle where a pannus develops in the area of the ulnar styloid. So what happens, that pannus develops and it starts destroying the structures around the dorsal ulnar aspect of the wrist. You get dorsal subluxation of the ulna, and with further destruction, you get supination of the carpus, which allows the distal ulna to stick out even further dorsally. And then the extensor carpi ulnaris tendon sublux ulnarly. Okay, so once you have the ECU tendon sublux ulnarly, you got unopposed pull of the radial wrist extensors, and then the wrist starts deviating radially, and you start getting the zigzag deformity. So if you look at this here, here's an early, so radiographically it can be quite subtle. If you see here on this diagram, that's pretty subtle right there. If you magnify that, you can see a little lytic lesions on the tip here, and maybe a little lytic lesion here, but you get an MRI and you can see there's this sizable pannus in this area that's causing those problems there. So it could be that you're the first person that makes a diagnosis of rheumatoid arthritis. It starts there often. It's good to look for that. The zigzag deformity, it can be in the flexion extension plane and in the radial ulnar plane. You see in the radial ulnar plane here, you see that the radius is, the radiocarpal joint is deviating radially, and then you get weakened structures at the MP joint, and then the alignment of the tendons in the intrinsic contracture allows the fingers to flex or to ulnarly deviate over time. So a couple classifications, I don't want to belabor this, but the Larson classification is a radiographic classification. A lot of the rheumatologists in their studies use the radiographic classification. And it's basically goes from a normal joint to a joint that has severe destruction, mutilating type disease. This classification I like because it's simpler and it may be more appropriate for deciding on surgical treatment. This is a Simon and Huber classification. Type 1, it's an ankylosing type. You'll see patients that have long-term rheumatoid arthritis and their wrist looks relatively straight, and they may just have disease in the finger, and you get an x-ray and their wrist is autofused. So that's already been taken care of for you. And then the osteoarthritis type looks a little bit more like osteoarthritis, and then you have the disintegrative type, which it just, everything's falling apart. There's no ligament stability, the bone's being resorbed. And that's a severe problem that you got to treat early surgically to prevent it from being a mess. So here's the different types. Here, this one you can see has ankylosing here. So this is the ankylosing type. This one, if you look at it, you can see there's an osteophyte here. There's some enlargement and osteophytes on the distal radial ulnar joint. And the joint's pretty stable here and well aligned. That's osteoarthritic type. And then here's this type that just destroys the joint and it just starts falling apart. This is a patient, as soon as you start seeing this happen, you want to fuse the wrist because the longer you wait, the bone's just going to dissolve. And this probably, if it was caught earlier enough, could have been, a lot of bone could have been preserved by fusing this early and getting rid of the joint and the pannus involved with the destruction. Okay, so here we were talking about, so the rheumatologist perspective versus the hand surgeon. And this was a study done out at the University of Michigan by Kevin Chung, I think is the one that did it. Was this before your time or after your time?
Just before, but Kevin Chung was there, and they're in the plastic surgery department. But they do a lot of hand surgery there as well, yeah.
Yeah, this study was interesting. So even looking at, so this diagram here shows whether they felt that there was adequate information to decide on surgical treatment. And if you look at our high quality studies, and hand surgeons only felt 54% of the time there was, which is fairly low, lower than I would expect. Rheumatologists only felt there, 20% of them felt that there was adequate information to make any kind of decisions about surgical treatment. Specifically looking at particular wrist surgeries, this is looking at, the top diagram is looking at effectiveness of resection of the distal ulna in rheumatoid patients. And you can see the p-values here. They're basically all significant here, but whether it improves wrist function, 65% of surgeons felt it did, where only 22% of rheumatologists. And you go right down the line here, there's a discrepancy. I am happy that there's a closer correlation with these tendon ruptures between what rheumatologist thinks and we think, because the last thing you want to do is have a rheumatologist hold on to the patient until they have 2 or 3 tendon ruptures. Once they have over 2 ruptures, it becomes very hard to do the reconstruction. So you want to get to these people early when they have maybe just their small finger tendon rupture or even just the EVQ rupture. So that's good that there's better correlation there. Improvement of supination and pronation, you see the discrepancy there. I'll show you in a later study, but what I found with the studies on DARA procedures is that forward rotation's pretty good in these patients that we do DARA procedures on in rheumatoid patients. It was surprisingly high. I think that already, so you're not really going to improve on that dramatically, and they're going to have good rotation afterwards. The osteoarthritic patients that have DARA procedures don't do as well. I think they start with a lot less rotation there, and that's why we're doing the DARA procedures on the post-traumatic patients. So effective of soft tissue reconstruction. Let's see here. So there's a better correlation with decreasing pain with soft tissue procedures and wrist fusion. Function, this surprises me with the wrist fusion, that the rheumatologists, only 50% of them feel that improves function of the wrist, because a lot of these are the patients you're doing, younger patients, higher demand patients that really need a stable functional wrist, and it's dramatic what they can do after the fusion.
It's kind of funny that they think we do relatively better on preventing tendon ruptures as opposed to other stuff like
yeah. Just general surgical indications, pain relief should be #1 indication, improve function. And then I mentioned prevention of progressive deformity on those severe mutilating type disease of the wrist, and then prevention of impending soft tissue injury. So preoperative planning is important with these patients. They're not your standard patients, so there's some specific things about rheumatoid arthritis you need to consider. So you want to assess the proximal joints and contralateral wrist to decide, because that may affect what you decide to do surgically. Pulmonary disease is pretty common in these patients. It's more common in male smokers, seropositive patients, and those with long-standing disease. And there are patients with pulmonary fibrosis, so that needs to be discussed preoperatively. For coronary artery disease, just pretend they're diabetic. They're similar to diabetes, so you need to consider that. And then for cervical spine instability, we've discussed this at other talks, but with instability of the C1, C2, you can get neck pain that radiates to the occiput, painful sensory loss of the hands, and 31% of these are asymptomatic. So you got to consider that in every patient you're going to operate on. So this just shows here, you can see different between flexion and extension views. With the flexion view, you can see that the distance between the C1 and C2, the occiput here, you can see how that opens up here. Normal is less than 3. So if you have somebody with a larger than 3 millimeters, probably that patient should go to the to see a cervical spine specialist before you decide any kind of surgery. My take on this is if I'm going to do a block and I'm worried about it, they have pretty severe disease, I'll still get the films. And I'll also want to talk to the radiologist or the anesthesiologist to make sure they can do fiber optic intubation, worst case scenario, if not get a cervical spine specialist consultation prior to doing the procedure. I don't know how you guys all feel on.
I almost never get them anymore because I've talked to anesthesia about it and they say they know everyone who has it. They know they have to be very careful with the airway, and probably just because the blocks works. I'm not saying it's right or wrong, but I used to give them, but I don't get them anymore.
Yeah, I just almost forgot about it over the years because you haven't intubated anybody so long. It's so rare these days. It's kind of not part of my typical protocol anymore.
Yeah, it's good to remember it, and I probably would remind anesthesia in that situation if you feel like their block isn't working and you're gonna have to go that route, just because they may get cavalier with it too, because they're doing so little general anymore. So I think we're ultimately responsible probably if something happens and we didn't get it. But
Yeah, I remember the guy from Pittsburgh, James Herndon. Do you remember that guy?
mm-hmm.
When I did my little trip there when I was a med student, he had a day that he did all rheumatoid patients. Every single one of them, he had the C-spine flexion extension films up on the thing. But I agree that now we're moving to block. I think it's definitely less important. Certainly, maybe those findings, if you have a person with neck pain, any of those instability findings with, painless sensory loss of the hands that you can't explain or neck pain that's in the occiput area, I'd probably get flexion extension films, at least in those patients. So perioperative medications, when I did this talk 10 years ago, this has been updated, and it was American College of Rheumatologists and the American Hip and Knee Society, I think, got together and determined these recommendations. So these are for major joints in the lower extremity. So we could probably even be a little less careful than they are. But the conventional and biologic DMARDs are known to increase post-op infection as well as impair wound healing, and direct communication may be necessary in particular patient cases. But if you look at these, all these, the DMARDs, the non-biologic DMARDs now, none of them, there's no recommendation to stop those. And I think most of us, as far as methotrexate and hydrochloroquine, we basically are ignoring that the patients are on those these days. With the biologics, you have your whole host of recommendation, and it's based on the timing the patients get them. But biologics, they are, at least for lower extremity surgery, they are recommending stopping them in the perioperative period. And you can see all the different variations here. Min, what do you think? Okay, so here's the different biologics here. So Remicade, Humira, Enbrel. What do you think? So see how some of these are ending with MAB, MAB, MAB? What do you think that stands for?
Oh, but the monoclonal antibody.
Yeah, very good. Very good, okay. Yeah, so that's how, one of the ways you can tell if they're monoclonal antibodies. And basically how those work is they clone these antibodies, and then they are specific for a specific antigen, or and so they can attack, whatever antigen you have on a cell or a structure you're going after. And that's been a huge advancement in medicine, for all sorts of things, cancer and also rheumatoid arthritis here. So one question I know we've asked, is there been a decline in hand surgery with the advent of biologics and DMARDs? This was a nice study, and it's harder to do the study in the US, and in places like UK where they have a whole population goes to one place for their rheumatoid surgery, you can do a better study like this. But this diagram here shows when DMARDs started, okay, or no, when they became active, when they started helping patients. So this year here, this is when we started using biologics, and this is when they started being effective, where you would see a change in need for surgery. So if you look at these three groups, I can't read this, but one of these is, can you guys read that? Is that?
Yeah, so the green says finger, the gray says wrist, and the blue says soft tissue.
Okay. So here you see, yeah, so with hand surgery, you can see when biologics started to become effective. It's interesting that it went up a little bit, and now that it's become effective, you can see a drop in the numbers. This is a way of looking at it a little different. It was rheumatoid surgery per hand consultant in Derbyshire. And you can see when the biologics started to become effective, you can see the drop off in number of surgeries they're performing. So yes, there is data that shows that biologics are decreasing the rate of surgeons that are hand surgeons are doing. Here's an observational cohort study looking at all comers. This is the hand surgery portion. You can see in 2001, 2005, 5.8, and it goes down to 3.4. The biggest decrease is in knee surgery. That's decreased from here of 11.5 down to 2.1 over the years. Interesting, foot and ankle surgery is the only one that's gone up. And I theorized here that, okay, when I got done with my fellowship, or my orthopedic residency was in 97. And I remember it was like one guy went into foot and ankle, and I'm like, what? I didn't even know there was such a thing as foot and ankle, fellowship. And probably what's happened here is that there's more foot and ankle specialists out here treating these patients. And then as they've treated the ones that were neglected all these years, then it starts coming down again.
I'm surprised shoulders gone down, just the amount of shoulder replacements overall gone up so much. I thought it was just doing a lot more of them.
That's true.
The treatments got better, the outcomes got better, but yeah, maybe rheumatoid specifically has gone down.
Let's see if is shoulder in here? Shoulder and elbow.
Yeah, so
And that's
2.5 down to 1.0.
Yeah, that is surprising.
Down a little bit. It goes up to 2020. Yeah, maybe be different in the US compared to UK or something. I don't know.
Oh, they may be doing less. Although Europe and
Europe, France
more.
especially doesn't.
So surgical options, if you look at your two options, you can do prophylactic surgery to prevent tendon ruptures, and you can also do reconstructive procedures where you're actually fixing tendons that are ruptured or doing arthrodesis or replacing joints. Want to touch base on arthroscopic wrist synovectomy. How many of you guys have done an arthroscopic synovectomy for a rheumatoid patient?
Like one or two.
Yeah, I can't remember doing one. How about for gout? I've done a few gout, severe gout that aren't responding to medical management. I've gone in and debulked them, but
like often there's enough outside of the joint, extension tendons, synovitis, or even gout, tophi, that we kind of going outside the joint anyway. I tend to just do it open.
Right.
yeah, and not go into the joint.
Yeah.
Yeah.
Or if need be, then make a separate arthrotic. You already kind of open the skin. But
Yeah, so if you look at the indication, persistent synovitis for greater than 6 months with medical management, you don't want somebody with severe arthritis to try to do this arthroscopically in stable soft tissues. Chung did a study and Kim and Chung did a study, and they looked at 30-month follow-up and showed improvement in pain, joint motion, inflammatory markers, and disability scores. The second study done in 2007 recommended it for pain relief and functional improvement, and it did improve range of motion or grip strength. I agree with George that it's usually not isolated. It's usually you got severe extensor tendinosynovitis, and I'm typically not even looking at radiocarpal synovitis. I'm just doing an extensor tendinosynovectomy on those patients that end up in the office. So with flexor tendinosynovectomy, so this patient right here, Alex, what do you think would be the symptoms of that patient on the right? Patient comes in with rheumatoid arthritis, a lot of swelling in the volar forearm and into the palm. What would be some of the things you would be looking for in that particular patient?
carpal tunnel.
Number one, yeah. What else?
Like trigger finger symptoms.
That'd be reasonable. What else? How about the tendons themselves?
Like ruptures.
Mm-hmm. Yeah. And what would be the most common rupture you would see in a rheumatoid with wrist arthritis plus or minus flexor tendinosynovitis? What's the most common tendon that ruptures in the wrist?
Ring finger.
That's the extensor side. How about the flexor side? The FPL is most common. And that's usually arthritis at the STT joint that ruptures that tendon. Do you know the name of that? It's called Mannerfeld syndrome. That ruptures. But this is a patient of mine that had severe flexor tendinosynovitis and carpal tunnel syndrome, so you got to do an extended release, and you can take out quite a bit of inflammatory tissue in those patients.
You're right about triggering. So yeah, not all triggering comes from the A1 pulley, right? You can definitely get triggering of a digit down here, and it'll look just like a trigger finger, but it often hurts there when it triggers as opposed to there, and you can feel it kind of catch on the flexor retinaculum. So yeah, definitely look for that.
If you look at extensor tendinosynovectomy here, it's also kind of, you always want to fail medical management. And with the biologics, you may even want to touch base with the rheumatologist to say, to ask him, when do you expect the biologics to make a difference here? Cortisone injections, how many of you guys inject, if you have a root-and tendinosynovitis, inject for a rheumatoid patient? Yeah. The concern would be attritional rupture. You already got tendons that are in bad shape. It probably has nothing to do with the injection or the disease, but if it happens a week after you do an injection, it is a little bit, can be looked. The patient can look at you sideways, but the goal is to prevent attritional ruptures. On this diagram, you can see that it's on either side of the extensor retinaculum. You'll get a swelling here, and then the extensor retinaculum in between here is what separates where the swelling is. I used to do a bigger procedure like this. I no longer do that. I leave a 1.5 centimeter strip of the extensor retinaculum, and then I just work on both sides of it. You can look at the entire tendon, and you can get under it without detaching it, because once you detach it and try to re-repair it, even if you do a Z-plastic lengthening or step cut lengthening, it scars more, and I don't like that technique. The bony abnormalities that they talk about that you're trying to cover up with the one on the undersurface is typically around the distal ulna, and if you're going to have to you're typically going to take the distal ulna out if there's a problem with the capsule on that side anyways. So extensor tendinosynovectomy with DARA, and we'll talk a little bit about ulnar translation later. You want somebody with minimal arthritis of the radiocarpal joint. Otherwise, you may want to do a different combined procedure. But I kind of have two different things I look at. If the patient's older and less demand, I'll do a DARA by itself. I don't worry about soft tissue interposition or anything, and I'm just careful with the capsule and make sure I do a good job with raising a large flap capsule that can be closed later. In the younger patient, I'll still do this occasionally, which is a DARE with a pronator interposition. This just shows I do it's hard to get, here's the insertion of the pronator on the ulna. If you're going dorsally and trying to detach that and bring it through, you're going to detach it here, and it's just not going to work. So I do a volar approach and detach it as far ulnarly as possible, and then I pass that tissue between the resected stump. I usually don't resect that much, between the resected stump, and then attach it dorsally here. Theoretically, it's a dynamic depressor of the ulna, and it's also an interposition because you're not denervating the muscle, and the blood supply is still good, so it should still be a functional muscle transfer.
You're just a guy bringing the
Anybody do anything different on that?
Who knows what did that happen?
It's a good technique. Sometimes I use a strip of the ECU, like one half of the ECU, put it through a drill hole.
Yeah.
I've done that one before. Seems most of the people I do DARAs on are older, and I just try to take off, like you said, and leave good capsule and repair it, and I haven't had stump impingement or instability, but I'm sure at some point that can happen.
Yeah, and some patients tolerate the instability. I have people that, you hear it when they're rotating it and they have absolutely no symptoms. So I think you can get away with instability on some patients. DARE results, these are old studies, and it's not like there's any new studies out there, but I think we've kind of figured this out. These studies show 93% pain relief, 87% restoration of forearm rotation, but again, the rotation on rheumatoids, a lot of times they have pretty good rotation still. And one thing they did find is that rheumatoid patients did better with DAREs than patients with post-traumatic osteoarthritis. You can see the satisfaction here is only 36% in osteoarthritis, compared to 86% in rheumatoid patients. This study was done a while ago, but I don't know that the techniques have changed where that's going to make a difference. So the thing you worry about with DAREs is instability and ulnar translation. This study found a 44% chance of ulnar translation after a DARA at 7.4 years. So if you look at, it's a little out of order, but if you look at long-term results, couple things to note is you do lose a little bit of flexion after a DARA procedure. You lose about 10 degrees of flexion. If you're doing a tendon transfer, just think about that. You're going to lose a little bit of flexion, but if you have 30 degrees of flexion, your tenodesis effect of your transfer is still going to work perfectly fine. So I don't think there's much concern about a 10-degree loss of flexion. The other you can see here too. See, they started preoperatively at pronation 80 and supination at 76, and it's about the same. So you're not really improving motion. They already have really good rotation before you even do the surgery. Visual pain analog scale showed a significant improvement, and grip strength was maintained but not necessarily improved. So ulnar translation, the easiest way to measure this is this galula lunate uncovering. You measure the width of the lunate, and then you take a parallel or perpendicular up from the ulnar margin of the radius, and you do the calculation BC over AC to get the percentage of uncovering. And they looked at normal risks up to 50%. So I don't think you even worry about this unless the patient has more than 50% of uncovering there, that'd be a problem preoperatively. This is that study done in 83, 38 patients, follow-up at 7.4 years. And they used a different way of measuring this, but he found 20 patients had grade A, which means it's translated 1 to 5 millimeters. 14 had 6 to 10 millimeters of translation. 3 had more than 10 millimeters. This is just one of the diagrams showing 13-year follow-up with 6 millimeters of translation. It's a little confusing here because doesn't that look to you guys like there's autoarthrodesis?
Yeah.
Looks like it's fused. I'm almost wondering if the angle of the x-rays have something to do with this. So I'm not sure about that study there. But so ways to prevent it, you got a couple different ways. You can instead of doing a DARA, you can do a suave-Capangio procedure to stabilize the ulnar aspect of the wrist to prevent ulnar migration. Or you can do a DARA and then do a limited wrist fusion, radiolunate arthrodesis to prevent further progression of the translation. Any other options you guys do for that?
Well, I just wonder what people do, because I have the patients who have the bad, ulnar deviation of the fingers, and their wrist has some of the, translation, but they have good cartilage and good range of motion and being. So it's hard to tell that person that I need to fuse your wrist first before I can fix your fingers. I don't know what the right answer is for that. I mean, I've done some that if it's really bad, but if it's mild, I just tell them to live with it. And a lot of times they can because they don't want to have their wrist fused, and I can't say as I blame them. I guess you can do the tendon transfer to rebalance it a little bit, and I've done that with mixed results. I don't know about you guys if you've done a lot of it.
Yeah, I do find a lot of them stay pretty darn functional. So
Yeah.
a lot of synovitis where I'm worried about pending rupture, I often don't kind of force people into surgery like that.
Yeah.
Because even with the radial deviation and, I think it's still function pretty well until it gets so severe, then it's more obvious.
Yeah, a lot of times they have the extensor tendon subluxation where they lock a lot, which can be mistaken for they get sent with a trigger finger. That's a common one by even sometimes the rheumatologist, and it's really their ECU tendons subluxating, and it's all starts because the wrist is jacked up, and sometimes a splint can help those people too. Like it makes them function a little better.
So we just talked about partial wrist arthrodesis. It's primarily for radiocarpal arthritis. If you see ulnar translation of the carpus, you may want to add that to prevent further ulnar translation. Radiocarpal instability, and then DARA procedure that we talked about. If they have some mainly radiocarpal arthritis, but some midcarpal arthritis, you may want to add a wrist denervation with that.
Do you usually just do the radiolunate, Jim, or do you do radioscapholunate?
I would do, on a patient like this, I'd probably do radiolunate. I've done for traumatic arthritis, I will do radioscapholunate if they have radiocarpal arthritis.
What would be the difference? I've never done any of those kind of partial wrist fusions like that. Is that either try to keep that scaphoid ability to flex and extend a little bit to maintain more motion by just doing a radiolunate fusion?
Yeah, I don't know if you get more midcarpal motion if you leave the scaphoid, maybe a little bit, but
I take out the edge of this end of this distal end of the scaphoid to leave a little bit more midcarpal motion. But obviously it's a rheumatoid, so they fuse pretty easily. But with some of the stronger meds, I don't know if that's quite as true. I would almost always do radioscapholunate.
Are you putting a plate on there?
No, I'll do screws. I've done plates, but a couple.
To get a stronger fusion. So
Just so there's more fusion surface.
Mm-hmm.
And I guess so if they still have their scapholunate, I guess that's sort of assuming as a rheumatoid they're going to be kind of lax, and they're still going to be able to move between their scaphoid and their lunate, even if it's fused.
Possibly. I don't know. I don't have an answer for that. That'd be a good thing to look at midcarpal motion after radiolunate fusion versus radioscapholunate fusion. The question is, where are you going to find enough patients to do a good study?
Right.
But that makes sense to remove the distal pole of the scaphoid, like Terry mentioned.
It's like a centimeter or so.
Yeah. Tim had mentioned staples are good for this also, and this well, that's showing a screw there too, but But I have seen a lot of radiographs of using nitinol staples that work well for this. Here's a long-term follow-up of these fusions, 14-year follow-up. This was basically one study that was reported like 10 years ago, and then they just redid the study on the same patients another 10 years later. And so what they found was good results, stable ulnar translation. That makes sense with once you fuse a radiolunate, it's not going to translate anymore. There was 10 with progressive midcarpal arthritis and 6 with stable midcarpal arthritis. One thing that was interesting, they found that if there was increased preoperative ulnar translation that they had to correct, there was a higher incidence of midcarpal arthritis in those patients if you had to correct a larger amount of ulnar translation. But they found good results in maintenance of wrist alignment, long-term follow-up. And then finally, total wrist arthrodesis. This is an older thing. You can older slide here. You can see the, I don't know, is that a rush rod or a Steinman pin fusion there that they used to do in the olden days? I don't know of anybody that uses Steinman pin anymore. Plates are pretty good, but it's good for pancarpal arthritis with pain, radiocarpal instability, those patients that you want to prevent bone loss. And then they found similar fusion rates between intermedullary Steinman pins and plates. Plates had lower complication rates and better final wrist position. If they do have contralateral disease and you're not a total arthroplasty guy, which I don't know of anybody in town that's done, has anybody done a rheumatoid total arthroplasty? Total wrist arthroplasty?
Yeah, I did them when I worked over at UNC with Bynum, and one or two a long time ago.
Yeah.
Yeah, I don't know what happened. I'll be honest. I mean, they didn't resurface, but I just read too much in the literature about complications, and I don't have that many that need bilateral.
Yeah, with bilateral, if you're thinking they're going to need fusion, then they recommend fusing the dominant hand and slight extension and ulnar deviation, non-dominant hand and slight flexion for hygiene.
The problem is the bone stock is usually not great in these patients, and so the implants will loosen and not have good fixation if you have a total arthroplasty. So
yeah.
The last woman I saw was from the DC area. I can't remember if she had RA, but she had a total wrist put in up in her in DC for basically something that could have had a PRC or scaphoid excision, midcarpal fusion. Mm-hmm. And she just came back because she was hurting and having pain, and it wasn't infected. It wasn't loosened that I could see, but she just had a lot of chronic swelling afterward. Mm-hmm.
And you worry about with the bone quality with plates also, but I think initially it was like, oh, are these plates going to hold? But now with locking plates and all that, they seem to hold up well. Just a little bit about the plates. Several vendors have pre-contoured plates. The top one has a larger bend here. That's if you don't do a proximal rocarpectomy. If you do a proximal rocarpectomy, you need a smaller bend. I like the proximal rocarpectomy in patients a lot of times because I like using that bone for the fusion, and there's also less areas to fuse if you've removed these 3 bones. So I'll pretty quickly go to PRC initially with fusion.
2 comments on wrist fusion and hardware. One is, I don't know if they still make it, but I have used the Skeletal Dynamics. It's like a intramedullary device that goes in the radius and the third metacarpal. One of the guys I used it in was a quadriplegic who was very thin on his skin, and I just worried about the plate. And other than the connector coming loose, probably because it wasn't seated right by me, that one worked out well, and I've used it a couple other times, but I don't know if they still make it. The other one is I recently had a woman who had a fair amount of ulnar translation, and she'd been like that for a long time. But I think Acumed makes a wrist fusion plate that goes from the second metacarpal to the radius, and that worked better for her because otherwise I would have had to try to move her over a lot, and it would gonna be really hard.
Okay.
Yeah, because her third metacarpal was almost over her distal radial ulnar joint.
And that wasn't the bone spanning plate, that was specific for wrist
That was
arthritis.
specific for wrist arthrodesis, yeah.
Good.
And so she ended up being just a little bit on the deviation.
She was, but she was balanced. She wasn't like the fingers were, so that's why I didn't try to correct that,
Yeah.
because it didn't really want to budge.
Might be kind of functional.
Yeah.
You know, like kind of help out.
She's used to it.
Yeah, that's good.
I mean, the studies show good results with fusion. Here's a 20-year study on 20 different wrists. Painful, durable stability, improvement in activities of daily living. And then there's a study from 2014, 94% of the patients were very pleased and 6% were fairly pleased at 45 months. So it's a good procedure, and I do think there's pretty low complications rates on it, despite it being a big surgery in a rheumatoid patient. And that's it. Thank you.